Alterations in integument, skin, hair, and nail disorders. Some different terminology that we need to be aware of includes the term pruritus. Pruritus is basically itching. So, how do we deal with itching in our client? Well, treatment would include the administration of antihistamines, whether it's oral or topical, lotions to hydrate the skin, increased fluid intake, bathing with warm but not hot water, or decreasing the uh, amount of bathing that you're doing, because too much bathing can also dry the skin out. Another medication we may administer may be some of our corticosteroids to help decrease inflammation. Cool temperatures, a high humidity, keeping that skin well hydrated. Mild soaps, non-perfumed soaps, and different deodorants, uh, non-perfumed lotions and deodorants. Changes in the skin are the most readily recognized of all signs of physical aging. And once again, remember that wrinkling is one thing that we may see. We have a decrease in the sweat glands, so their skin is going to be drier. We also have a decrease in sebum production, so there's less oil to moisturize the skin. And that will be, once again, apparent in our women much earlier than in the men. The skin is going to be very dry. They're going to have itching as we get older. The skin is going to pale because of the decreased number of cells that produce melanin. Skin lesions are going to also be more common. Those lentigines, the liver spots, those dark brown, almost like a large freckle on sun-exposed skin. The senile purpura, those purple-like discolorations on the skin. They look like bruises and they come from minimal trauma and they resolve very slowly. The senile angiomas, or those bright red spots. Seborrheic keratoses, lesions that vary in size. They might be flat or raised. And the acrocordons, the skin tags. And remember, by the age of 50, nearly half of all older adults are going to have some gray hair. Men can begin losing their hair from the scalp in their 40s and sometimes much younger. And they may also be almost bald by the age of 80. Women will have the thinning hair. They uh, Both genders will have an increase in the facial hair, in the nares and the eyebrows and the helix of the ear. Women can start growing facial hair around the mouth and the chin. Nails begin to flatten, become dry and brittle and discolored. So then we talk about dermatitis. Dermatitis is going to be an inflammation of the skin. We've got two different types. We have an allergic contact dermatitis. This will occur in clients that are sensitive to one or more substances. It may be something that they come into contact with their skin, or something that they ingest, such as a medication or a food. And the primary irritant dermatitis, which will occur from a chemical exposure. With dermatitis, we may see a localized rash, we may see a generalized rash. If this is the coming from contact, so contact dermatitis, it will be contact with a substance that causes a reaction in the skin. So potentially it may be poison ivy, for example. This is going to be an area where it comes in contact with the skin. If it's a soap or some type of a perfumed lotion, wherever it comes into contact with the skin is where the rash may develop. But if it's something ingested, a lot of times we'll see what we call the generalized rash. If it's a medication, for example, they can have a rash over the entire trunk or over their entire body. So these clients are going to have some dilation of the blood vessels. They're going to experience itching or the pruritus. They may also experience some blistering. Medical management. We've got to remove the substance that's causing the irritation. If it is a contact, we are going to flush the skin with cool water, use topical lotions. We may do corticosteroids, whether it is topical or oral, and wet dressings. Nursing, make sure that you wear rubber gloves if the client was in contact with a chemical as we're cleansing it. And we should always use gloves to apply the topical treatments. Maybe encourage a second laundry rinse cycle to get rid of some of that soap in the clothing. Avoid the use of substances until it's determined if it's a causative agent. Sometimes it's a process of elimination. True or false? There's many different etiologies for dermatitis. This is false. While there's a lot of different allergens that can result in dermatitis, dermatitis is going to basically be an allergic reaction to a specific substance. And while there's a lot of irritants, the etiology of dermatitis is that allergic reaction. Acne. This is a skin condition that commonly begins in adolescence and it can last into adulthood, and this affects the sebaceous glands and the hair follicles. We basically have an overproduction of sebum, too much oil. These clients may have an oily scalp. They may develop the comedones or pustules, which are the pimples. How do we treat it? Well, they need to keep their face clean with gentle cleansers. Use agents that are going to help dry out some of that oil. They may use topical or oral drugs. Some clients that have severe acne may be put on antibiotics. Pimples should be removed with instruments. We can do dermabrasion, which would remove surface layers of scarred skin. As far as nurses, we need to encourage the client to keep their hair and skin clean and avoid using any oily products. But what is really important to understand about acne is their specific foods are not going to cause acne. I don't know how many of you watch TV, but Dr. Pimple Popper, Dr. Sandra Lee, she is a renowned dermatologist. Her comment is pizza only causes acne if you rub it all over your face. So, foods are not going to cause acne unless you rub it all over your face. Rosacea. This is a chronic skin disorder that's characterized by a rosy appearance. The cause of rosacea is unknown, but it may be caused by bacteria or mite infestations. We see an increased blood flow that can last hours or days, and eventually it can become chronic. It can develop unevenly thickened and distorted skin surfaces. These clients may have intermittent blushing. They may have papules or pustules. They may have swelling of the face. The rhinophyma, which is a permanent enlargement, typically of the nose. We have a reddening and a nodular surface of the nose. Rhino meaning nose. There's no cure for rosacea, but treatment will involve minimizing symptoms, may require oral antibiotics or topical medications. There may be a pulsed light treatment to improve appearance, especially if we're talking about the rhinophyma. Nurses need to help determine triggers and minimize sun exposure and encourage the clients to follow a basic skin regimen. A furuncle. This is a boil, while multiple boils would be called furunculosis. A carbuncle is a boil in which there is pus. So these are usually caused by skin infections, and they can also be associated with diabetes mellitus. Diabetes mellitus, if you think about it, we have high blood sugar. Sugar is a food source for bacteria, so bacteria grows very easily with diabetes. So these clients are going to have painful pustules that are surrounded by erythema, localized fever. There may be a systemic fever. Client may experience anorexia, that lack of appetite, weakness, or malaise. We can do hot wet soaks, will require antibiotics, may require surgical incision and drainage, which we call an I&D. We should use strict aseptic technique when we're caring for these and encourage the client to not pick or squeeze the sites. Any cloth that's used around the site should be washed separately and use bleach to help kill the bacteria. So true or false? Furuncles, furunculosis, and carbuncles are treated with antibiotic therapy. This is true. Cellulitis is a common bacterial skin infection, and it can cause redness, swelling, and pain in the affected area of the skin. The bacteria gets into the body through openings in the skin, and it may be just a very almost microscopic opening. These clients are going to have reddened skin. Again, it might be swollen, painful, might be warm to the touch. It may have a pitted look to it, like the peel of an orange, or may have blisters. Client may also have fever and chills. And if you look at the picture below, you can see cellulitis in that lower leg and foot. We treat this with antibiotics. It is important to keep the wounds clean if there is an open wound, and always use good hand hygiene. Psoriasis. This is a chronic, non-infectious inflammatory disease where we have an excessive proliferation of skin cells. Plaque psoriasis is the most common type of psoriasis. The cause of psoriasis is unknown, but there is likely a genetic predisposition. But it also requires a triggering mechanism, and there may also be an immunity component. Some people can have systemic effects of the disease, such as psoriatic arthritis. These clients are going to have erythema with silvery scales and/or lesions. There's no cure for psoriasis. We can do symptomatic treatment and drug therapy, biologic therapy to help decrease the lesions and the severity of the lesions, and photochemotherapy. These clients often have a lot of scaling. They take off their clothes and there's scales all over their clothes, might be scales all over their bedding, all over the floor, etc. Infestations. Well, we have two main types that we talk about in this course, one of which is scabies. Scabies is an infestation with the tiny itch mite. These are spread by skin-to-skin contact. It does not involve poor hygiene. The itch mite will burrow into the upper layer of the skin and it lives there and then starts laying eggs. We often see it between the fingers, between the toes, etc. So these clients are going to have intense itching and they can have some excoriation where they're scratching and they actually scratch open wounds. We treat it with a scabicide application, thorough bathing, clean clothing, and avoiding contact with those clients that are infected. We have to advise these clients that itching can continue for 2 to 3 weeks post-treatment. Nurses should always wear gloves when caring for these clients. Clothing and bedding should be washed in hot water. Pediculosis is going to be an infestation of lice. Lice are transmitted through direct contact or sharing of personal items like combs, brushes, or clothing. We see itching of the scalp. We may see brown crawling insects about the size of sesame seeds. We may see small yellowish or white ovals on the shaft of the hair. These are called nits. We may see small gray nymphs or silvery eggs, once again attached to the hair shaft. We treat it with pediculicides, mechanical removal. Understand that lice are developing strains that are resistant to chemical extermination, so it's very important to follow the recommended regimen to get rid of them and follow it meticulously, or you may develop a strain of lice that are resistant to what we're trying to do. Nursing management will involve education on detection, education on not using hair conditioner prior to the application of the pediculicide, teaching the client that all people within the home should be inspected, that these clients should wash their clothing, the bedding, vacuum furniture and carpets. If there are items that are unwashable, place them in a plastic bag and seal it for a couple of weeks. Lice can live up to 10 days off of a host, and nits will die in about 10 days. However, they have to have a body temperature temp in order to survive. So they've got to have that temperature close to a human's body temp to survive. Again, washing those clothing in hot water. Dermatophytosis. These are superficial parasitic fungal infections. They're also known as tinea and more commonly known as ringworm and athlete's foot. This fungus will invade the skin, the scalp, and the nails. We may see rings of papules or vesicles that have a clear center. They have pruritus. The skin may be very sore or tender to touch. We treat it with oral or topical antifungal agents. These clients should use separate towels, washcloths, grooming articles, and clothing. They need to dry themselves thoroughly after bathing. Avoid tight-fitting clothing. Wear footwear in community showers. Don't walk around barefoot in community showers. Uh, they can use a vinegar water soak to help remove the crusts if they build up on the feet or elsewhere on the body. Herpes zoster. This is more commonly called shingles. It's caused by the varicella zoster virus, and this virus also causes chickenpox. It will lie dormant in the body for years. So basically, it's going to be a reactivation of the varicella zoster virus in someone who has previously had the chickenpox. This will usually happen in the mid-adult years or older adult years. The symptoms are going to occur in one or more of the cranial or spinal nerve routes. So if you look at the picture here and you remember how the nerves run in the body as they come along the spinal cord, then they kind of wrap around the body. This is what we call a dermatome, and that is the typical appearance of shingles. It's going to follow the route of a dermatome. So these lesions can cause ulcerations in the eye, in the ears. They can actually go up the nose. They can go to the brain. I used to care for a lady who had a stroke because of shingles. They can cause vertigo, permanent hearing loss, postherpetic neuralgia. In other words, after the herpes has resolved, they can have pain, that nerve pain, for months or years, and this pain can be very severe. These clients are going to have raised, fluid-filled, and painful skin lesions with inflammation, once again, in the dermatome, which is the area of the skin that's supplied by that nerve, itching, that postherpetic neuralgia, or pain that can persist for months or years. We can administer antiviral medication if we give it within 48 hours of the onset of symptoms. If we give it within 48 hours, it can lessen the severity or lessen the duration of the shingles outbreak, maybe even prevent additional lesions. Then we also treat symptomatically. But prior to a client having shingles, we should encourage vaccinations. These vaccinations are very important to help prevent the outbreak of shingles. As far as nursing, we should discourage contact with people that have never had the chickenpox or been vaccinated for the chickenpox. We can use cool or warm compresses, whichever feels the best, and encourage the client to wear loose clothing. Skin cancers. There's three basic types. Excuse me. They are classified as non-melanoma or melanoma. Non-melanoma skin cancer risk factors include sun exposure or tanning bed use, especially in a client that has a tendency to sunburn. Fair skin with freckling, light-colored hair, light-colored eyes, especially blue eyes, maybe light green eyes, male gender, and cigarette smoking are all risk factors. So the different types of skin cancer include basal cell carcinoma. This is the least serious of all of the skin cancers. It is painless, round, nodular lesion. It may have a pearly appearance to it. They tend to grow very slowly and they rarely metastasize. We treat it with surgical excision, maybe the Mohs surgical procedure. This is where thin layers of the cancer-containing skin are progressively removed, and we examine them under the microscope until we reach cancer-free tissue. We can do electrodesiccation, curettage, cryotherapy, radiation, or topical drugs, or drugs that may be injected directly into the lesion. We can do topical chemotherapy that is applied either as a preventative, or we can apply it directly on a lesion itself. We can do it after the removal of a lesion. So indications include the non-metastasized basal or squamous cell skin cancer. Again, we can use it for prevention of some skin cancers. Make sure you always wear gloves when you apply this. Adverse effects of topical chemotherapy include irritation at the treatment site, and this irritation can last weeks or months after treatment. Clients should avoid direct sunlight or exposure to UV rays during the entire treatment period. There may be pain or itching or burning at the site. There may be flushing of the skin or a loss of the skin. There may also be crusty, dry skin at the site of application. Examples of topical chemotherapy would be like our Fluorosil. Squamous cell carcinomas are the second type of skin cancers. These are scaly ulcers. There may be a flat or raised lesion. They can also be caused by overuse of tobacco and alcohol. They can develop on sun-exposed areas, and this includes the lips and in the mouth. They grow rapidly and they do metastasize. Treatment may include surgical excision, cryotherapy, and radiation therapy. And then melanomas. These are the third type of skin cancers, and this will be the picture in the lower right. These develop from an increased exposure to ultraviolet radiation and fair skin, especially, you will have an increased risk. Melanomas will arise from that pigment-producing cell in the skin. It's the most serious form of skin cancer, and if it metastasizes, it can be fatal. It can also be found anywhere on the body. They have irregular borders and uneven coloration. Many of them are dark, but some are light. They might begin as a tan macule that begins to enlarge. These clients will have a new appearance of growth. They may have a change in skin color. We can treat it with electrodesiccation, surgical excision, cryosurgery, radiation therapy, chemotherapy, and immunotherapy. So as we're trying to identify melanomas, we follow the ABCDE rule. A is asymmetry. B is border irregularity. C is a color that's not uniform. D is a diameter greater than a pencil eraser. E would be an evolving change in that lesion. We should encourage these clients to use sunscreens and lip balms with sunscreen, wearing of a hat with a wide brim, staying in the shade, using sunglasses with an ability to block out 99 to 100% of the UVA or UVB rays. Avoid artificial tanning. Avoid prolonged sun exposure, especially between 10 a.m. and 4 p.m. because that's when the sun is at its strongest, and recommend a thorough monthly skin examination, especially in clients that are at higher risk for skin cancers. Actinic keratoses. These are considered precancerous lesions that are generally found on the face, the neck, the forearms, and the back of hands, areas that are frequently exposed to sunlight. They may become malignant if they're not treated. They're most common among older white adults. They appear as a papule or plaques of irregular shape. The hard scale on the lesion might shed and then reappear. And treatments can include drug therapy, cryotherapy, surgical excision, or electrocodesiccation. Seborrhea and dandruff are non-inflammatory conditions that sometimes are accompanied by seborrheic dermatitis, which has an inflammatory component. Seborrhea is caused by excessive secretions from the sebaceous glands. The scalp is going to be the primary site, and dandruff might be caused by a fungus. These clients may have oily hair, they may have red or scaly patches on the scalp, or white flakes coming from the hair, and itching. These clients need uh, frequent shampooing with or without medicated shampoos. They may require corticosteroids. We need to teach these clients of the need for that shampooing and the potential for this condition to recur. Usually people think if I have a, excuse me, if my scalp is itching, it's because my skin is dry, instead of thinking, well, it's dandruff and it's caused more from excessive oil rather than being caused from dry skin. So they may over moisturize their scalp instead of trying to get rid of some of that oil. And nail disorders. We know that clubbing of the fingers is caused by chronic hypoxia. So this is a condition that does not happen overnight. It's going to happen over an extended period of time. Nails are going to be subject to disorders that include fungal infections or ingrown toenails. Fungal infections can easily spread from one nail to another, and we usually see this in the toenails. We may also see elevated, thick, distorted, or loose nails. They may also be discolored, being more of a yellow color and being very friable or very fragile. They may require prolonged systemic drug therapy to improve this, may require the removal of the nail or surgery. Nurses should encourage compliance with drug therapy and encourage the client to alternate their shoes daily if that is a possibility. Don't go barefoot. Wear footwear at public pools or showers. Excuse me. Ingrown toenails usually occur on the inside edge of the great toe. This might be caused by an inherited trait, a fungal nail infection, improper shoe fit. In other words, the shoes are usually too tight, or improper trimming of the nails. These clients will have swelling, redness, pain, maybe purulent drainage, or an odor coming from that ingrown toenail site. We need to treat that infection. We can soak the foot with warm water and Epsom salts. We may need to lift the edge of that nail, pull it out of the skin. Surgery may be required to remove the edge of the nail. Again, encourage those foot soaks and relieve pressure around the nail. See the podiatrist if the client is diabetic, if they have vision problems, excuse me, or they have vascular problems. And now your post-test.